Hi, my name is Marley Emery, and today we'll be talking about the newborn challenge of a cleft lip, the maternal challenge of a yeast infection, and their breastfeeding relationship. Their pathophysiology, signs and symptoms, diagnosis, treatment, nursing supports, and evaluation will also be discussed. I also have a lovely team of 1 month postpartum mums with us. They're going to help us with our topic. Let's start with cleft lip. Cleft lip is formed during the 4th to 7th weeks of early pregnancy when the lips are beginning to form. If there's not enough tissue, then a separation or split will occur in the middle, one or two sides. It can also occur with a cleft palate, which is a hole to the top of the mouth or a split, or a microform cleft, which is a smaller, tiny red-like scar from the nares down to the lips. Can anybody tell me the odds or precipitating factors?
Oh, pick me. I know. The odds are about 1 in 700 babies annually, and it's the 4th most common birth defect in the United States. Now, if you're Asian like me, or Latino, or Native American, then you've got a higher chance of developing a cleft lip. As well, twice as many boys as girls develop cleft lips. Now, I bet that's why we stopped at 8. I mean, our little Tom has one.
In many cases, the cause is unknown. However, there are genetic and environmental factors that do come to play. Anticonvulsants, anti-seizure medications, and acne drugs such as Accutane and methotrexate all contribute to the development of a cleft lip.
Teacher, don't forget the other risk factors like smoking during pregnancy, diabetes, having an older mother, obesity, or using certain medication to treat surgeries.
Good catch! So, can anyone help me out with the diagnosis and some of the challenges? Anybody?
Diagnosis is simple, with a newborn physical exam or prenatally via ultrasound. Some challenges that exist are breastfeeding challenges, difficulty gaining weight, middle ear infections, speech problems, dental problems, and sometimes jaw involvement when teeth are misplaced, misshapen, or extra.
Hey buddy, you forgot the other breastfeeding challenges. You know, sometimes it's very difficult for the mom and the babe because the infant has a sucking insufficiency, which can impair the establishment of full milk production and milk transfer sufficient for infant growth. This actually puts the infant at a risk for growth failure and sometimes even aspiration. Other challenges can also include psychological difficulties because moms are often unable to breastfeed and are required to pump, especially if the infant is not born at full term and has experienced any birth trauma, medication, or other health concerns post-delivery.
These guys are fabulous! Now, which one of you want to talk about priority number 1?
I had a baby with a very bad cleft lip, so I'd really like to talk about priority number 1, maintaining infants' weight, because that's something we struggled with. Infants are at very high risk for not maintaining or gaining weight, and the first priority is to monitor the infant daily and assess their nutrition. Tracking their feeds, weighing their diapers, daily and weekly weights, as well as the length of feeds and amount of express breast milk top-up is key for this priority. Now, we need to safely feed the baby. So if we cannot feed the baby with the breast, we need specialized squeezy bottles, regular bottles with nibbles with enlarged holes for fast flow. As well, we can also use spoons and plungers. If we are able to breastfeed and we can encourage that, then oral feeding should last no longer than 20 to 30 minutes because longer feedings can lead to a net caloric loss due to excessive energy output. We need to watch for signs of aspiration such as frequent coughing, choking, sputtering, or color change, as this feeding method may not be safe for the babe.
That was excellent. Who hasn't spoke yet? Maybe Mr. Green in the back should talk about the breastfeeding relationship.
Ooh, I'm on the spot. Well, good thing I did my readings. I'm going to make priority number 2, supporting the breastfeeding relationship. You see, if breastfeeding becomes a struggle, then a mom may not establish that same breastfeeding bond, especially if this is her first baby. She might struggle with the unknown. It's good to assess her knowledge of breastfeeding, her knowledge of cleft lip, and maybe any prenatal education she's accessed. It's a good time to point out any strengths, some skills she might have, but also take note of her limitations and her learning needs. Assessing her nipples and her breasts, maybe the presence of a breast colostrum or milk, will help to determine the best position for feeds and if she's able to provide the top-ups necessary to maintain infant weight. At this time, we should also look at babe. Their gestational age, available energy, health, ability to latch, and some feeding cues should be noted, and their initial comfort with breastfeeding and effective milk transfer during breastfeeding should be assessed.
I just wanted to cut in and say that breast milk is very important because it provides babes with a higher protection from middle ear infections.
Wow, thanks for that really informative interruption. Some recommendations include feeding upright, specialized bottles, which we talked about earlier, latching the baby onto the breast while expressed breast milk warms, alternating breast, massaging, trying various positions, teaching good positions such as a cradle and football hold, as well as a laid back position. These help the breast mold itself into the cleft to make a good attachment. It also helps put the weight on the cleft side of the body. Also, I have seen moms hold the cleft closed with their fingers. I just really wanted to cut in and mention that I had a cleft lip babe, and I never had any feeding difficulties at all. Some moms don't have any troubles. I mean, sure, there was engorgement, and maybe I didn't think I had enough supply when I really did, and I didn't have enough support or information, but heck, breastfeeding wasn't an issue at all.
Wow, it's great to know that sometimes there isn't any difficulties, and sometimes things just work out really well. I guess that's why assessment is important. So I guess we should also assess if you're unable to pump or latch, to consider other signs and symptoms of infection, such as mastitis, abscess, maybe a yeast, before declaring that breastfeeding is actually the issue, strictly due to the cleft lip. These babes also need treatment. It begins in early infancy with 1 or 2 surgeries. These surgeries are usually performed before 3 months of age, with the goal of improving the appearance of the lip and the nose, closing the openings to help breathing, and stabilizing and realigning the jaw.
Hey, Mr. Green, don't forget that they need extra nursing support during this time, especially around surgery. You see, we should be educating on pumping and various feeding devices mentioned above until the infant recovers from surgery and is healthy enough to reestablish this breastfeeding relationship. We should include some important professionals in their care, such as lactation consultant, physicians, public health nurses, and any breastfeeding groups or clinics. Great points. I completely forgot about that. Let's evaluate both of these first 2 priorities regarding the cleft lip. Now, I think that we should have some physical proof of weight gain and output for the infant, successful transfer of milk, successful establishment of milk production, and the ability to pump and top up. Perhaps even the positive connection between mother and infant if they are currently unable to breastfeed. For example, we should have them bonding, skin to skin, and creating a good attachment. If one of these goals we had for the infant and the mother are not met, then I think that those health professionals, Mrs. Yellow, listed, can be contacted so that they can assist in creating new ways or ideas to approach the problem so we can have a positive outcome.
Great job, guys. Let's talk about yeast infections. Hey guys, our next topic is yeast infection. Candida albicans is the most common occurring Candida species found on the mucosal tissue of the mother and the child. It's a presence of yeast in the vagina or the infant's mouth. As a pathogen, it can cause a very distressing fungal infection in both mom and babe, resulting in nipple and breast pain for the mother and difficulties feeding it for the infant. The cause of this is antibiotics or a compromised immune system, and it can be very distressing. 96% of women are experiencing breastfeeding pain in the first 6 weeks of feeding, so it's very important to distinguish if this pain is due to thrush or to another cause. Pain is the #1 reason for women stopping breastfeeding, so early diagnosis and treatment while providing supports is essential. We first must rule out attachment and positioning by revisiting the infant's efficient milk transfer and latch, because this may attribute pain to the breast other than yeast. Other causes should be ruled out, such as engorgement, infection, or skin conditions. Who would like to talk about signs and symptoms?
Oh, the signs and symptoms. I've had several yeast infections, and my gosh, all I can talk about is red, pink, shiny nipples, or sometimes perfectly normal, even more frustrating. They might have white patches on them or white patches in the infant's mouth. They might have deep, penetrating pain. Oh, the pain. And sometimes, it's good to know that your breastfeeding relationship's great, because then you really know when you're in trouble. Starts with a good latch, and then all of a sudden you're sore and painful, and your baby's fussy, and their mouths are sore, and they won't stay on the breast, and they're letting go and popping off the nipple during feeds, and the history of antibiotic use, because, gosh, we're always on antibiotics. Well, at least I can say that I never had a fever or inflamed areas of the breast or misshapen nipples after feeds.
I'm so sorry, Blue Guy. That is very upsetting. I hope you got the help that you needed. And I'm sure everybody else feels the same way. I think so. Who would like to talk about diagnosis and treatment?
Diagnosis. I'd say that about 80% is based on patient history alone, along with the development of white patches on the infant's tongue or a vaginal infection with a woman of a history of antibiotics. The tongue and hard palate of the infant may also become inflamed, making it painful to latch and breastfeed. Some of the symptoms and signs that the woman will be able to mention to the healthcare physician will help and aid in the diagnosis. Most of those were listed by poor blue guy earlier. Treatment involves infant and mother being treated at the same time. Gentian violet may be applied to the nipples, or metronidazole, limidazole, or nystatin creams. Antifungal medications may also be used. Other homeopathic remedies include oregano oil, a vinegar rinse, ingestion of grapeseed extract, diet changes, ingestion of acidophilus, and rest for the mother is always encouraged. The ultimate treatment, which I think should be priority number 3, is to treat the pain while encouraging breastfeeding. I'd like to talk about that too, please. Census?
Aye, aye.
Okay, go ahead. All right. Priority number 3, treat the pain while encouraging breastfeeding. The first step is to assess the mom's knowledge about yeast infections while breastfeeding. Perhaps this isn't the first time for her. Perhaps she has some strategies already. Acknowledge her strengths and experience in the breastfeeding relationship. That's always a positive. Take note of her limitations, educational learning needs, and current breastfeeding relationship. That will help with recommendations and evaluation. Don't forget about the baby assessment. Thanks, Pink Lady. I was getting there. The baby assessment is also important. Any infant factors such as a gestational age, birth experience, oral anatomy, feeding behaviors, current latch, and any other health conditions that may affect breastfeeding. If you consider the mother's breasts as well, and any potential complications she may have occurred since the babe not feeding regularly, such as engorgement, mastitis, infection, things that may have occurred to impair milk transfer recently, then that's also great to assess. A lactation consultant, physician, or public health nurse might also be great options to assist with breastfeeding during and post-yeast infection. Some of the supports that you could include would be helping the mother to latch or improving her current latch now that babe's having difficulty staying on. Try some different positions to alternate the pressure areas that may be sore on both mom's nipple and the infant's mouth. Apply express breast milk to the nipples along with prescribed creams and allow them to air dry. This may help with sore nipples. Alternate breasts, feed on the least sore breast, massage, apply warmth prior to and after feeds to give mom some relief as well. Use of over-the-counter inflammatories such as Advil and pain relievers such as Tylenol are recommended until the pain subsides. Ensure that the mother understands that regular emptying of the breast must occur, whether this be breastfeeding or pumping, to ensure that adequate milk is still being produced. Sorry to interrupt, I just have a couple really quick tips for mom, such as not freezing any milk during this time because it will contain fungal spores. As well, please wash all your clothing that touches mom and babe because heat is the only method of eradicating candida. Also, it is good to include a post-birth assessment when teaching breastfeeding, as early intervention and treatment is the most important to support the continuation of breastfeeding. Thrush can also be linked back to attachment problems, resulting in mastitis, and then you start antibiotics, causing a yeast infection. I just thought you should know. Wow, thanks, Yellow Lady. Yep, definitely some good tips. So, for evaluation, we should really evaluate the mother's experience of pain. Is it better, relieved, maybe completely gone? We could physically observe the white patches on babe's tongue to be reduced or gone as well. And mom's yeast infection, is it clear? Mom's evaluation of her breast and physical evaluation for redness, soreness, and shininess should also happen. As well, the latch and attachment for breastfeeding should appear improved with lessened or eliminated pain for mom and longer feeds with less pop-ups of the nipple during a feed.
You guys have done a great job. Let's sum it up with some key points. Cleft lip causes an insufficient suck, resulting in a risk for infant growth failure and aspiration. Some of the things we can do are monitor babe's weight, feeds, and use top-up methods such as express breast milk with squeezy bottles, specialized high-flow nipples, plungers or spoons to help babe maintain weight. Assisting with the breastfeeding relationship, especially the attachment, for different holds like the cradle, football, laid back, so that we can mold the cleft into the breast will help improve efficient milk transfer and successful breastfeeding. Now, regarding yeast infection, pain is the #1 cause stopping breastfeeding relationship. Let's find out its source. Look, is it sharp, severe, painful, especially with breastfeeding? And still, when you're not breastfeeding, is there white patches in your babe's mouth? Is there a history of antibiotic use? This may mean a yeast infection. Early intervention and support is key. So we have to pursue treatment methods and support the woman to decrease her pain, and in the meanwhile, to continue a beautifully harmonious breastfeeding relationship.